would like to begin the March meeting of the Quincy Dems, and I sincerely want to thank Bonnie Gorman, who is a member of our Ward 1 committee, along with, where's Lyn? There's Lyn Newkirk,
yeah,
and Sandy Eaton, and we're excited to have you this evening and to speak on Medicare for All. And I turn the meeting over to the three of you. Thank you for joining us.
well, thank you for having us. We really do appreciate it. We just wanted to emphasize a few different activities that are going on, and I'll talk a little bit about the bill itself and the need for the bill. And Lyn is going to talk about the initiative petition that we're starting with 2 reps here in Quincy. And Sandy is our historical reference point on Medicare for All and our petitions here, both in the city, in the state, and in the nation. So Sandy is also a nurse as well. So in terms of why do we need this bill, particularly in a time of COVID, this bill, COVID has disrupted health insurance dramatically. 5 million people have lost their jobs, therefore losing their health insurance, at least that number. And so the health insurance marketplace has been disrupted, and it will never really be put back the way it was, because so many people are doing contract work and that does not come with benefits. So we really have a growing population of folks that need health insurance that needs to be separated from a job, a benefit with your employer. So I think that is something that Medicare for All does address, in fact, quite extensively. It really is a Medicare for All. It is like our senior Medicare, but it is much more elaborate in terms of types of service. We can save 11%. So wait a minute, here's the number money. There's a need as well for savings in the current healthcare system, because we are paying a variety of for-profit health insurance folks who have escalated the cost of healthcare by 276% in the latest study. And that is just a rapid. I mean, it's the period of time is a 20-year period of time, 276,000, 276% escalation in healthcare costs, and only increasing. We do have, at that same period of time, inflation has been at 50%. So we really have a continuing escalation, and it's unaffordable. So we have these high deductible plans, with $6,000, $7,000, $8,000, sometimes even $10,000 deductible that has to be met before anybody can go for any health insurance. Now, the goal of them is to pay a low premium, but you're not going to be able to get your health care if you have to wait for you and your family to wait for $6,000 or $8,000 or $10,000 deductible, and so people are not getting the care that they want.
Bonnie, when you say that, that's the spend down. That's referred to as the spend down. You have to spend between $5,000 and $10,000 of your own personal money before your insurance will kick in.
Right.
That's referred to as the spend down, correct?
Right.
I want people to be understanding what she means when you say you have to spend that amount.
Yeah. And so, And for people who really cannot afford much in the way of health insurance, they are buying these high deductible plans, and they're not getting health care as a result. So we have a reduced number of people in Massachusetts not getting the health care that they need. And then with COVID disruption and the jobs disruption, we were lucky enough to be able to get federal money to supplement some of the health insurance plans, but it's only short-term money. It's not long-term money, and they're threatening to stop that this year, the additional subsidies to the current healthcare plan. We do have also we have gone from 66% of our costs of the bankruptcy for health insurance folks has now gone up from 66% to 75% cost, because people cannot afford their health insurance. And this is in Massachusetts. I mean, we do provide more health insurance in this state than most other states, but we are still struggling, and the escalating cost of health insurance is just totally out of control. And this bill would provide some rational costs of managing the money, and saving $11,000 is, I think, we have on our plan information. We sent out, oh, maybe it hasn't been sent out then. We have a description of the bill that looks like this. I can personally get it to all of you. And that outlines this in more detailed form. We also have a initiative petition information that Lyn Newkirk is going to be talking about here in Quincy. And we are also sent out, or if it's not sent out, it will be sent out after the meeting, a 20-minute summary of why we need Medicare for All, in more of the medical details what will be included, as well as the cost analysis details. So those you will be getting, and we'll make sure they get out to all. Alicia has that information, and we'll make sure it gets out to all the members of the Quincy Democratic City Committee. And yes, feel free to use this video as well to send out to folks. We have no problem with that. So with that, Lyn, you might want to just talk a little bit more about the financial aspects and the initiative petition.
Thank you, Bonnie. Yeah, so one of the things that people are always asking about is how are we going to pay for Medicare for All? And first of all, there's been numerous studies done over the years that show that Medicare for All actually saves us money. These savings are going to come from reduced administrative cost, negotiated drug prices, along with hospital and physician price adjustments. So the remaining shortfall is going to be funded with and this is the mass bill that we're talking about. The shortfall would be funded with a 2.5% payroll tax to employees and 7.5% to employers, along with a 10% tax on other income. Now you have to remember, these taxes don't kick in until you make at least $20,000. And these taxes do not apply to retirement income, Social Security, SSDI, and unemployment. So these taxes in most cases are going to be significantly less than what people are currently paying for their health insurance and out-of-pocket healthcare cost. And then staying with the numbers, when I was doing some research for Medicare for All, I found that it has a big impact on our local towns and municipalities, because health insurance costs are considered a fixed cost in town budgets. They must be paid for, right? And so when these costs are rising, it's at the expense of other town and city departments. Our schools, roads, and water and sewer, along with other city infrastructure, are suffering because of these increased fixed costs. In Quincy, the budget, I took a look at it, the increase in employee health insurance was 7.12% for the fiscal year 2021. 7.12%, that's a lot. And it represents 15.44% of the total budget. Now, the executive summary talks about, it stated, all increases in the budget are attributable to fixed costs such as healthcare for employees. The town is acknowledging that the effect of the rising health insurance costs. So this current trend is really not sustainable, and is just one of the reasons why we really need to move to a single payer system now. And that's just some financial stuff. I didn't know, Sandy, did you want to give Did anyone have questions, or Sandy, do you want to talk about the historical background on this?
Yeah, thanks, Lynn. Thanks, Bonnie. Thanks, Alicia, for inviting us, and hi, Patrick, and everybody. Happy International Women's Day, in case anybody's forgotten. I've spent my entire career as a registered nurse at Quincy Medical Center, which we don't have anymore. And we're the largest city in New England without even an emergency room. Every corporate entity in Massachusetts healthcare has found a beachhead in Quincy to capture market share. But you can't say that if I have a stroke tonight, that I'm going to get to an emergency room in time to be effectively treated, or a heart attack. With a Medicare for all, expanded and improved Medicare for all, a single payer universal healthcare system, everybody's life will be valued equally, no matter what kind of insurance you have, whether you're employed or unemployed or whatever. And with a more stabilized, funding stream, we may not have lost our hospital. We might not have lost our emergency room. We might not be 100,000 person city with increasingly diverse culturally and linguistically population, with an especially large elderly proportion of our residents, worried about where they go from there. Historically, the folks in Quincy have always been very welcoming to these ideas of fundamental healthcare reform. South Shore Medicare for All, which is the group that the three of us represent, is about a year or two old, and we're sort of a local hub of MassCare, the Massachusetts Campaign for Single Payer Healthcare. When we were founded in 1995, and I was there, since then we've had 36 ballot questions. The city of Somerville, any number of Senate districts, and an awful lot of state rep districts, with a single payer non-binding question on that in November's ballot. In Quincy, the second Norfolk district, which is where I live, in 1998, we got 77.7% of the voters say yes, they wanted a single payer universal healthcare system. Without the interference of insurance companies or other bureaucracies blocking our access to healthcare. It's a clinical decision that needs to be made by a clinician and an individual, not by bean counter somewhere else. This year, we've also, in other years, we've done the 4th, the 5th, and I think the 6th Norfolk districts, for example. And again, everywhere it carries by a huge margin. This year, our group has decided it's time to do the 3rd Norfolk and the 3rd Plymouth. Now, the 3rd Norfolk has South Quincy, parts of South Quincy, Quincy Point, about a third of Weymouth, and 2 precincts in Holbrook. We have folks around throughout the district that are pledged to work on this. The other goal we have is the 3rd Plymouth, which is Hingham, Hull, and Cohasset. And the folks out that way are eager to dive in. So again, this is non-binding. What it does is give activists in fighting for a just healthcare system an opportunity to get out and talk to people. And the 2 years of the pandemic has restricted our ability to get out and talk to people in the same way. And I think we're all sort of sick of being stuck on Zoom so much. But this will be an opportunity this spring to collect signatures, and then spend summer and fall actually talking to people, and letting elected officials know that the Massachusetts Democratic Party platform and its plank around healthcare justice are worth having and are worth fighting for, and not just words on paper. So I think in a sense, all of this work we're doing is bolstering those progressive voices who are delegates to the issues conventions that have stood up for healthcare justice, which essential to which is a single payer financing mechanism. I put in the chat an email address for our group. if anybody, as an individual, or if the Quincy Democratic City Committee wants to endorse or join or just get on our mailing list to get a monthly newsletter about what's going on in terms of this particular campaign and related campaigns looking for healthcare justice, please, sign up. We'll be glad to keep in touch and hopefully work together as we go forward. Thanks
Lyn,
again.
did you want to?
Yeah, I just wanted to follow up. Thank you, Sandy, for talking about the ballot initiative. I believe most of you know there is a bill, Medicare for All for Massachusetts in the State House right now. And we've got a lot of support, but it's not looking like it's going to be brought up for a vote this session. So we're just working for this for the next session and education and this ballot initiative. So yes, we're going to be in the 3rd Norfolk district, and we're going to be collecting signatures to get the ballot on the question on the ballot in November in 3rd Norfolk, and also, as Sandy said, the 3rd Plymouth. But we'd love to have anyone who wants to help collect signatures or do some canvassing to get out the importance of Medicare for All. We'd love to have you join us. So please, Sandy said he put the email in our in the chat, and also he just put in, we are the South Shore Hub of Mass Care, which is a statewide organization working for single payer healthcare. So we'd love to have you join us. Contact Bonnie, Sandy, myself. We'd just love to have people come and join us. We're going to have ballots. It should be ready the end of April. And we're going to start knocking on doors as soon as we can to get the signatures that we need in Mariano's district. And as you guys know better than probably most, it's just that little hunk of Quincy, but then it goes down Weymouth and Holbrook. So we're going to be reaching out to the DTCs in Weymouth and Holbrook as well to get their support. And we've actually already talked to Weymouth, and we're getting some support there. So we hope you'll be able to join us.
Right. Melissa?
You've talked about insurance companies. What are the hospital buy-ins for this? But I'm wanting to know how the various hospitals, particularly since we're in such a heavy hospital area to the north of us.
Yeah. Sandy, you want to take that?
Oh, I'm itching on the edge of my seat. Thank you, Melissa. Just a little anecdote. In 2005, as we were gearing up toward what became known as Romneycare, I was invited on behalf of MassCare to debate an alternate point of view in a class at the BU School of Public Health, the single payer version. And the class was full of young hospital administrator wannabes in getting their masters or whatever. And that was the very question. They all wanted to know if a public insurance would give them enough reimbursement and so forth. Well, that's it. If we have this kind of a system, the system we have now is haves and have-nots. Obviously, Quincy is a have-not, and the folks that can go and other towns. Stewart Healthcare deprived Quincy, but it had a lot of help. Partners, which is now known as MGH Brigham, deprived Lynn of its community hospital and its emergency room. Where folks are well insured, nobody's ever going to close down services at Newton Wellesley. It's all about money. So if we equalize the amount, like I said, the value of each person's health, the value of each person's life, no matter where you are or what your status in life is, or what your background, what your gender, or what your ethnic composition or your migration status, you are a free and equal human being, valued, and the money will flow to meet your clinical needs. That's what I told the class then, and that's what I believe, and that's what I still think is a firm argument for getting rid of insurance companies that add no value to healthcare. All they do is filter block. Other countries. My mother came down from Canada. I've worked closely with the nurses in Canada, the Canadian Federation of Nurses Unions. They fight like heck to keep their system from being Americanized. I won't get into more detail, but basically this profiteering system is bad for communities' health, and especially as you're coming through an epidemic, this pandemic, and you see which communities are most impacted and which are less impacted. Obviously, white privilege makes a big difference in terms of survivability, and there's a lot of things around that. But access to quality healthcare has to be open to everybody without financial considerations. And this way is the most efficient way to deliver healthcare to a large number of people, namely everybody. And that's the only sane public health perspective on this, that we're all in and nobody's out, nobody's excluded.
Okay, so I'm wanting to know a little bit more specifics. What have these hospitals said that if they have to change their prices for reimbursement for this? We're getting a lot of very much abstract and like, yes, this will go through after this is done, but I'm wanting to know more concrete steps.
Well, the transition will be the public trust will pay the bills instead of private insurance companies. And the bills will be submitted by the providers, whoever that happens to be, and they will be paid. If there's abuse in the system, as there is, I remember 40 years ago when a gastroenterologist I knew bought for only $3,000 a new endoscope. He was going to use it 30 times a day because he was going to make money on it, rather than when it's needed. What we need is to give healthcare as people need it. And anyway, you get my point. The money will be there because we're all going to pay into a trust fund, and it will be paid out of that. Do you not think it will be paid out of that? The federal government is very good on Social Security, for example. I've been retired for a few years now, and I've never missed a Social Security check. They're very good at paying bills when it's very clear. So the trust, whether it's at the state level or at the federal level, will pay its bills when they're submitted. And if there's evidence, if there's a pattern of abuse, as they do in Canada, retrospectively, they'll look back, and if there's a pattern of abuse, they will check into it, rather than denying services or putting you through the tremendous amount of waste in terms of paperwork going back and forth and so forth. It's a much simpler, more direct system.
Much simpler system. I think we know we have administrative overhead for Medicare is at 2%. The health insurance companies can be up to 30% in overhead and excess billing and just repetitive actions for health insurance companies, so that only 2/3 of the healthcare dollar goes to actually spending on healthcare. The rest is administration. And those can be all eliminated. Professor Jerry Friedman does a study here in Massachusetts, and the study basically says that we can save $11 billion here in Massachusetts on transitioning to a healthcare system. We can get you all of that data. And it is available actually on the MassCare website, which is the statewide single payer website. But we can follow up with the more detailed studies. I have sent, though, Alicia, the 3 pieces. You had your hand up.
To everybody, Bonnie. Thank you. All right. So my question, I have a couple, and I'll be quick. Regarding the initiative petition to put it on, is it the 3rd district? Is that Ron's district? It's non-binding. What is the point? And why have you done that in various districts over the years? And what does that gain you by doing that?
Sandy, you want to take that? Where's Sandy? Is he there? Yep.
He's there.
Link for some of our discussion. It gives us a chance to talk to people. We're building organization. Like I said, over the years, we've had 36 in the past. We had a 2-year hiatus, and we couldn't do that anywhere. And we're hoping
when
to
you
have
say 36 in the past, that's 36 rep
separate
districts?
ballots in a state rep, state senate, or the
Across
city of Somerville in
Oh, even
1999.
municipal ballots, you're
It
telling
can
me.
be done on the municipal ballot.
Okay.
The rules are a little trickier, but Somerville, I think it was something like 88% voted yes. The People's Republic of Somerville, I guess you'd call it. And it's been an overwhelming thing. It's an educational opportunity and it's an organizational. See, there are two issues with making fundamental healthcare reform. There's the political. You've got a bill in some legislature that you're trying to get enough political support, and it's ideological. There's people who think that the private sector can always do everything better. Well, the private sector can maybe get you a cheap computer that's very fast if you don't care about usually third world women going blind working in Singapore or Shanghai or Simi Valley. But it does not deliver healthcare to everybody. We've had this 40 years of neoliberal impact where anything with public on it has a target on its back: public education, public works, public healthcare,
Public service.
and public, right down the line. So I think that fits into that. It needs to be part of putting us back on our feet again, instead of only driving for profits for the 1%.
So that is, so when you go before these, what committee is this before? This bill?
The Joint Committee on Healthcare Financing.
And who are the
first thing.
chairs? Do you know?
What's his
John
name?
Law and Cindy Friedman.
Thank you.
Are there any South Shore
Yes,
senators?
Keenan is on that committee. Senator Keenan. Yeah.
Yeah,
Okay,
Senator
well-
Keenan has endorsed it.
Well, that's very helpful to know, in particular to our members that would want to speak to him regarding this issue.
Yes, please do. And
And he's actually in that district, because he lives in Marymount.
Yep.
No, that's Tacky's district.
That's
I'm
Tacky's,
sorry.
Yeah.
That's Tacky's. So,
I think we
Okay,
may
s-
be doing tackies as well. That is on the table, and I think we've got enough people to do tackies as well.
and
Well-
why do you target certain districts?
We want to target all districts. But
Okay.
as you know, a statewide question. I was very involved. As a matter of fact, I organized our first rally for patient safety on the steps of the State House in June of 1993. Very much involved. And so question one on the 2018 ballot, where the nurses lost, the patients lost 30%.
Patient
to
staffing
70%.
ratios.
It's very
Right,
difficult
right.
when
It's been-
$30 million
been around
worth of
forever.
around the clock attack ads come in. So actually we're under the radar screen of those who profit from the status quo in healthcare. So we haven't encountered that kind of a resistance. Maybe someday, there are two ways to pass legislation in Massachusetts. One is the legislative route, which we've been pursuing, and the other is the statewide ballot question. And as someone who advocated for a patient safety ballot question and got and suffered the defeat, I'm leaning much more toward the need for legislative action as the way to make law.
So, and then you take that forward to this committee and to the members of the general court to show them that the general public, through these various ballot initiatives that you've done, the support that the general public has, you show that as proof
Right.
that they should consider. I mean, it's got to be, you don't go through all that time and effort for nothing other than educating the general public, which is not a bad thing, but you must want to use those numbers in order to convince the legislature to pass the bill, right?
That's
Is
why
that
we have a
Yes,
hub-
oh,
a hub-
absolutely.
Okay,
Yes, as an
all right,
advocacy tool, no question.
correct, all right.
Yeah.
Thank you. So Medicare, what happens to Medicaid?
It's all rolled in. It's one pot.
Okay, it's
all-
one pot.
Yeah.
And everybody gets a single high standard of care. That's our goal.
So all those
Same
insurance
standard of
companies
care.
go away.
They've got many other things to invest in.
No, but
Every
I think we really have to get down to the very basics of
Yeah.
what you're talking about here. So, and I'm trying to, so my members understand exactly what you're saying when you're saying Medicare for, believe me, I am such an advocate. I've been on the Managed Health Board and wanting this That's my personal opinion. So,
Been a
but I
patient there
want
for many,
my
many
members
years.
to understand what you're saying. And that the Harvard Pilgrims and the Tufts will go away. The Blue Cross Blue Shield will go away, and it will be a system much like our Social Security system that is managed by the government.
Well,
And your plans that come through the government, not private insurance companies. Whether you're employed or not, you're going to get covered.
the
Yes,
Is
staff
that all
model,
correct?
Absolutely correct. Yes.
Harvard Pilgrim is also a staff model HMO. When you have a clinic with all of your specialties under one roof, that's not a bad thing. That's a good thing. It's the paying for it that gets complicated, and the financial barriers to getting in there to pay for it. I wouldn't want Harvard Vanguard and Quincy Center to go away. Some of my wife's specialists are there, but the way it's financed needs to go away so that everyone has access. And I just have to shout out to Manet and certainly to volunteers like Bonnie and the city of Quincy for having us be in the forefront of the vaccinations and the testing during the pandemic. That is a perfect model of why we need, and why folks I know who are at Harvard Pilgrim and some of the others were never called up. They're at PCP, never
No, they
called
were
them.
referring them to Manet.
Yeah,
They were
Manet,
telling
yes.
them to go there.
that's true.
So
Yeah.
we need a lot of Manets. We need a lot
Yeah.
of community centers, well-funded, hopefully better, and able to deliver the goods in terms of what people need.
Absolutely. So I guess how our members could consider this and look at this is that now the Harvards and the Tufts and whatever else, the Blue Crosses will be working for the government and under government regulations, not their own.
Correct. I mean, it's similar to the Medicare currently. I mean, they provide guidelines. It's a private event.
Right.
I mean, the providers are private. They are, and they organize themselves in certain ways. And this is their public health, like Canada. I mean, if one looks at the Canadian model, it's a perfect example of what it could be like. There's a wonderful video called "Fix It," film actually, 1 hour. On the Canadian healthcare system and the benefits of it.
Google that. All right. I don't mean
Yes.
to monopolize this any further. I really want to ask, is there anyone else that has any questions regarding this extremely important issue to many of us?
Winnie?
One of my concerns is I belong to a social club, and part of that club is in Canada. And I've been a member since like 88. So over the years, I've watched tall ladies come down to the United States to marry American men to get on their health care. Because the health care in Canada, at a certain age limit, you're not eligible for certain coverages. She happened to have lupus, and she was having trouble getting that covered. So she found somebody down here, married them, and now she's fine. She's got plenty of good coverage. But I've seen this over the years, that although Canada has a system where everybody can get insurance, there are a lot of restrictions on what you can get. Even on Medicare, I was on a medicine that I liked, but it was too expensive. They pushed me down to one that's not as good, but it's all I can get if I don't want to pay out of pocket. So my concern is that this Medicare for all, because I know costs, I mean, money talks, and you know what walks.
That's right. Yeah.
What my concern is are we going to be limited to what we can purchase out of this Medicare for all? Like if Joe Blow's brother works for for Pfizer, and his company is making this medicine, but the better medicine is made by somebody he doesn't know, do we now have to go with what Pfizer wants?
Sandy,
see,
you want
these
to
are
take
my
that? I
concerns.
think we're going to, the particular issue, and it's a Medicare issue presently, is we had no control of managing pharmaceuticals when Medicare was enacted. And the big the pharmaceutical companies have come forward and said they will manage the marketplace, which means for profit for pharmaceutical companies, not for patients. And I think, I mean, there will be times when there will be challenges over a use of medication, and they particularly costly medicines. But the goal of Medicare for All is to be able to manage and limit the pharmaceutical companies from the egregious profits that they're making now, and that for example, the Veterans Administration does have control, the only arm of government that has control of prices in the marketplace. They can demand, and Medicare ought to have that same benefit. They ought to be able to demand lower prices, because we are getting gouged here in the United States across the board, not just in Massachusetts. I mean, look at the issue of insulin. People are dying over lack of insulin, as just an example. So that would be built into the limitations of the prices through high cost pharmaceutical companies, and hopefully, and other countries, many other countries are managing those pharmaceutical prices, and with single payer. I mean, England is, Canada, they pay dramatically lower. You were talking about your friend Winnie in Canada.
Yeah.
A lot of people go to Canada, get their medications, because it might be 1/10 or 1/20th of what the cost is here it's actually the US. The US prices are just outlandish, and they're making up, but other countries, many other countries have price controls. Sandy, you want to take anything else on that?
Well, I just want to say that a lot of the kids born to parents in counties all across the northern rim of New England were born in Canada because they went over to visit their relatives across the border, because they don't get paid, they don't get stiffed with bills the way they do in this country. So I don't know how that does on their citizenship, and I don't know whether the closing of the border with the pandemic had any effect. A few years ago, the Liberal Party government in British Columbia tried to sneak through a provision for hitting senior citizens with bills for physical therapy, which is against the Canada Health Act. And they almost got unseated. There's tremendous pushback against that. I can say it's a political football everywhere you go, because we're talking about money and resources. I don't know about the particular what's available for lupus and so forth in one country or another, but I do know that the folks in Canada aren't fighting to get rid of their system. The head of certain corporate entities in Canada, like including the Canadian Medical Association, are fighting to get rid of it because it does limit their ability to get rich off of sick people.
Well, I don't mean to interrupt, but I want to say, ultimately, in the end, it's the U.S. Congress that has to change this. I mean, we have a bill before the Massachusetts General Court, but to really see this happen, it has to be a national.
Well, many of the states have been fighting it out. New York, California, Vermont. There are some special cases. Colorado. States are fighting folks are fighting at the state level because they don't have hope in what might happen in Washington. Looking at the situation right
now. That's all well and good, Sandy, that they say, we pass it here.
Well, we still have Representative Ro Khanna from California is the current lead sponsor of a bill to facilitate waivers to allow states to experiment and to go forward. The Affordable Care Act back in 2010 had provisions in it that, if you look deep enough, would streamline starting in 2017. Starting in 2017, the Affordable Care Act would have facilitated states experimenting in other ways to reach universal health care.
And you have to remember, Canada actually started in, I believe it says Saskatchewan.
Saskatchewan, yep.
And they saw that it was so successful there. That's what, expanded it through the rest of the country. So it can start on a local
Right,
level.
at a
Okay.
local level.
That's good to know as well. That to be explained and understood.
I know
All
folks
right.
who obstruct it who want to obstruct it at the state level tell you it's got to be done at the federal level. Folks who want to obstruct it at the federal level, folks in Washington tell, it can only be done at the
Send
state
it to
level.
the state.
Right, right, right.
And I really don't know. I have no magic crystal ball in front of me. I don't know where we're going to make the breakthrough first, but we are making the breakthrough across a whole front of struggle at all levels. South Shore Medicare for All is also doing whatever it can to get Steve Lynch educated on the issue for the federal level, the federal bill, of which only about, I think slightly more than half. I think there are 6 Massachusetts representatives in Congress that support the U.S. House bill, and both of our senators support whenever the bill has appeared, and Sanders introduced a bill in the Senate. So we've got a ways to go, but wherever
you have
we
to
are,
fight it on all fronts.
Right.
that's our philosophy.
That's the point. Yep. Yep. That's how you get it done. Well, I want to this is an interesting conversation. I hope our members found it interesting. And maybe if there's some type of a forum later in the season between Quincy, Braintree, and Holbrook that we could put together, if you wanted, and we could have a forum with the pros and cons. Well, we could discuss it, but I think there's more that, and we'd be happy to collaborate with you, is my point.
Sure.
So,
Yeah,
We'll
great.
go anywhere, anytime.
Nancy, did you have a question?
So first off, I completely agree that Medicare needs to be able to, to negotiate prices. I work in health insurance, and 80% of the questions I get on a daily basis are, why are my prescription drugs going up? And it's mostly at the generic level. So things need to get changed on that end. My question to more kind of, as I said, I work in health insurance, so I'm trying to understand this in my brain. So Medicare, as it stands right now, doesn't cover all. It's 80%, but then you have a supplemental plan and a prescription drug plan. So that's where the private companies are coming in as well into the federally ran program.
Right.
Does this take those away? And if it doesn't, these plans are across the board, and it's shocking to me how they're the regulation, because some of them are great, and then the donut holes and everything else, it's, again, cost for the consumer can go sky high when they think that they get a best of the best. They're getting sold by every retired football player this time of the year that they have the best plan since sliced bread. And then they have gigantic out-of-pockets or gigantic deductibles. So are you saying that the supplemental and the Medicare Part Ds are going away?
You won't need them.
Then how does that work?
You won't need them.
As a stand, if I'm a person on standard Medicare right now with a supplement and a Part D, how do you explain Medicare for all to those people?
It's expanded and improved. It is not Medicare as it exists now. Private entities have had 55 years to warp the single payer system for seniors and disabled that was enacted at the height of the civil rights movement in 1965. So it's degenerated over the years as different ways to find profit. Right now, the Medicare Advantage program, for example, is what you're talking about. There are other ways to force people into Medicare Advantage programs without their knowledge that are being dealt with right now. And the Physicians for a National Health program is spearheading the campaign to expose that and to have the HHS eliminate programs that are going to force people that are basically trying to privatize Medicare all the way across. And we're pushing in the other direction to expand it. And one thing about people that work in insurance, any single payer Medicare for all bill at any level that's worth its salt has huge provisions in it for just transition to use your skills or develop new skills to move into other areas of work, hopefully in an expanded healthcare system that is dedicated to delivering care and not to limiting
fair
care.
and equal care.
Yeah.
This has been fascinating. Went on a little bit longer.
I got one more question.
Who's gonna,
Mimi.
oh, Minnie,
Minnie.
sorry.
Hi, Mimi.
Go right ahead.
Hi there. My question, I guess, is now, is there anything that you'd advise people, say, don't get into that healthcare plan, that private Medicare supplement plan, or any way that you'd advise people to operate now while they're waiting?
Yeah, I think currently I recommended to refer to the counselors at senior centers. Shine, is it Shine?
Shine.
Counselors.
They're fantastic.
They know their stuff, and they can really help. They're amazing. They can really guide people through.
And what's interesting about Shine is that's a government program.
Exactly.
You go in and they teach you. And these are mostly retired people,
Right.
who have an earnest interest in helping people navigate the healthcare system and what plans to pick. And they are trained by the state government to do that at all of our elderly housing centers across Massachusetts. Elderly housing, I mean community centers across Massachusetts.
Yeah.
So I agree with Bonnie wholeheartedly. Go see the Shine counselor at the Quincy Council on Aging. Call up and make an appointment.
Great.
It's as simple as that.
I guess I meant politically, is there a move to make that you recommend for people, or?
Well, supporting the bill itself, and I will just say the numbers are they're 766 in the Senate. That's currently the bill in Massachusetts, and 1267. Let me double check that. 1267 in the House. We have about 85 co-sponsors right now, which is half of the nearly half of the House, and a good number in the Senate. We're still reaching out. Our delegations, Senator Keenan has signed on as a co-sponsor. We need to get Reps Ayers, Mariano, and Chan to sign on to the bill. And so that's something this group can actually do, and reach out and ask them why they haven't signed on to this bill.
Just understand that most of the times the Speaker or the Senate President don't sign on because of their positions.
Right. Yeah. But we still
Most of
want
us
to, I
understand
mean,
that.
if they hear from their constituents, that's an important voice for them. Yeah.
Right. So I sincerely want to thank the three of you. Bonnie, where are you? Sandy and Lynn, thank you so much. Look forward to working with you perhaps in the future.
Excellent.
Thank you for taking the time tonight. And we'll be sure to get that material out to our members.
Thank you, Alicia. Appreciate that.
My
Thank
pleasure.
you, Alicia. Bye,
Thank you.
everybody.
Take care. Have a good night. Thank you guys very much.